Postoperative pain is a global unresolved health issue. It is reported up to 80% of postoperative patients in Australian hospitals receive inadequate treatment for acute pain. Poorly managed postoperative pain results in increased morbidity, impaired function, decreased quality of life, medication dependency, increased medical costs, and the development of chronic pain. Chronic pain contributes to negative effects on a person's physical functioning and mood, causing experiences of depression, stress, sleep disturbance, and fatigue. Poorly controlled pain is a risk factor for hypertension, myocardial ischemia, arrhythmias, respiratory impairment, ileus, and poor wound healing. Medical costs include time taken to ambulate, increased length of hospital stay, and increased readmission rates contributing to increased cost of care. A number of factors contribute to post-operative pain. Preoperative factors include preoperative pain, anxiety, young age, obesity, fear of surgery, and psychological stress. Intraoperative factors include surgical approach, length of surgery, and area being treated. Abdominal, orthopedic, and thoracic surgery indicate increased risk of post-operative pain. Post-operative factors include radiation therapy, neurotoxic chemotherapy, and psychological vulnerability. Pain assessment is necessary in establishing the patient's pain level, allowing the selection of appropriate intervention and management. Pain assessment allows practitioners to identify appropriate intervention, prioritize management, and assess changes in a patient's condition. Pain management is necessary to decrease the patient's pain experience as well as reduce the risk of post-operative complications. Pain assessments aim to describe the patient's experience of pain, identify and implement appropriate management strategies, evaluate the effectiveness of interventions, and allow for the collaboration of the multidisciplinary team to achieve patient comfort. Pain may be defined as whatever the person experiencing the pain says it is, existing whenever the person says it does. As a result, it can be understood the best way to obtain a pain assessment is from the patient. Best practice for pain assessment is self-report. Primary pain assessment involves the PQRST assessment tool. This allows the assessor to guide an informed report of the patient's pain. Categorical scales tools, including the numeric, verbal, visual, and faces pain scales, may be used to assess pain intensity. Best practice dictates these assessments should be applied to pain on movement, indicating physical function levels, and at rest, indicating comfort levels. Furthermore, best practice dictates pain assessment should be assessed regularly and systematically. Assessment should be repeated according to ward or hospital policy. This may be hourly for the first 4 hours post-operatively. This may be increased or decreased according to the results. Pain should also be reassessed after pain management intervention to determine its effect. Challenges to pain assessment include neurological deficit, language barriers, and age. When the patient is not able to report their own experiences of pain, objective assessments may be made through the observation of pain behaviors and responses. The FLAC scale observes children 2 months to 7 years for face, legs, activity, cry, consolability to determine pain. Autonomic reactions such as sweating, increased blood pressure, increased heart rate, and increased respiratory rate can indicate the presence of acute pain in patients with neurological or language difficulties. Challenges to pain assessments exist as a result of the subjectivity of pain. Nurses using different scales make it difficult to track and identify changes in patients' pain levels. In order to maintain the validity and reliability of pain assessments, the same pain scale should be used at consistent intervals. This allows changes to be easily observed and acted upon. Consistency across pain assessments scales is limited in the clinical setting. Documentation often provides different scales provided by different nurses, limiting the reliability of the assessment. Changes to pain assessment guidelines and documentation should be adapted to support the individual's needs. This allows the assessment to occur in a way that allows for the best patient report and maintain consistent and valid reports of patient pain over time. Pain management aims to decrease the patient's pain experience as well as reduce drug side effects and prevent procedural complications. Pain management applies a holistic approach to patient care in order to achieve optimal results. Pain management combines both pharmacological and non-pharmacological approaches to increase patient comfort and satisfaction. The choice of analgesia depends on the type of surgery the patient is having. Procedure-specific pain managements are recommended where applicable. Opioid drugs are commonly used to manage acute post-operative pain. Opioids are beneficial for moderate to severe pain and can be administered through several routes. This makes it appropriate for the varying post-operative care requirements of different procedures. Opioids provide relief for both neuropathic and nociceptive pain, providing appropriate pain relief for different types of pain. Opioids can cause patients to become dependent on the drug for pain relief. This results in drug addiction in the long term. Furthermore, opioids can have negative side effects including respiratory depression, nausea, vomiting, constipation, and pruritus. Best practice involves the combination of opioid and non-opioid analgesics as a multimodal approach to pain management. The multimodal approach incorporates non-opioid analgesia in order to target different mechanisms of pain, reducing the overall pain effect while reducing the dose of opioid analgesics. Lack of research knowledge and education impacts the nurse's ability to advocate for and provide a multimodal approach. Nurses require in-services and further education within the clinical setting in order to administer nurse-initiated medications in conjunction with opioids to create a multimodal approach. Non-pharmacological methods can be used in conjunction with pharmacological therapy. Alternative treatment includes physical and behavioral therapy, providing a holistic approach to pain management. Best practice includes collaboration of the multidisciplinary team to provide alternative therapies for pain management. Alternative therapies include acupuncture, exercise, massage, hypnosis, meditation, and relaxation. These methods aim to reduce pain and improve function and mobility post-operatively. Challenges to the implementation of alternative therapies include lack of knowledge, transportation, scheduling, and cost of services. Limited practitioner and patient knowledge prevent patients from accessing and participating in alternative therapies. Facilities offering alternative pain management are limited, resulting in long distance and travel times for patients. Further funding is necessary to create alternative pain management clinics in the clinical and community setting. This includes the purchase of facilities and equipment as well as training staff. This allows greater access and availability to patients who require them. Effective pain assessment is necessary in understanding the patient's pain experience in order to implement appropriate pain management strategies and evaluate their effectiveness. A combination of opioid and non-opioid medications to create a multimodal approach can reduce drug side effects and prevent procedural complications. Alternative therapies contribute to holistic health and well-being, providing for a patient's comfort needs. A combination of pharmacological and alternative pain management strategies allow for positive post-operative results, including decreased morbidity, improved physical function, improved mood, and increased quality of life.